Welcome to the International Childbirth Initiative webinar series on the 12 steps to safe and respectful mother-baby family maternity care. My name is Michelle Skaer Therrien, and I'm the Executive Director of the International Childbirth Initiative. ICI is an implementation and quality improvement process that strives to achieve the 12 steps for safe and respectful mother-baby family maternity care through a self-evaluation and reflective process conducted at the facility level. ICI is also a global resource network of facilities striving to share their learning and improve the provision of care. It was created through the joint effort of the International Federation of Gynecology and Obstetrics and the International Mother-Baby Childbirth Organization. We include actually more than 30 partner organizations and continue to grow, and we're open to all birthing facilities who are willing to commit to delivering safe and respectful mother-baby family maternity care. Today's webinar is on Step 9, Provide Emergency Obstetric and Neonatal Services. Today's presentation involves several people. We prepared this with Dr. William Keenan and Dr. Douglas McMillan of the International Pediatric Association and Professor Suellen Miller of the University of California Safe Motherhood Program. All three of them are members of the ICI Executive Committee. I'm very pleased to be co-presenting with Dr. Vijaya Krishnan and Dr. Robert Tillya today. Dr. Vijaya Krishnan is a certified nurse midwife and the founder of the Sanctum Natural Birth Center in Hyderabad, India. And we're very pleased that the Sanctum is one of our ICI sites. Dr. Robert Tillya is a research scientist at Ifakara Health Institute, and I've had the honor of working with him for many years. He works on maternal and newborn health research and interventions, and his focus is on providing training and skills building to health professionals in both rural and urban settings to strengthen their capacity and reduce maternal and newborn mortality across Tanzania. Together, we are addressing Step 9, provide emergency obstetric and neonatal care and transport, provide access to skilled emergency treatment for life-threatening complications, ensure that staff are trained in timely recognition of potential dangerous conditions and complications, and in providing effective treatment or stabilization, have established links for consultation or an accessible and reliable system of transport. So some essential components of Step 9 are ensuring birth preparedness and emergency readiness during pregnancy through health promotion activities and organized community and health services mechanisms, and providing planning and arrangements for situations in which the mother or baby need care beyond the capacity of your available resources. This may include remote consultation, an effective communication system, and timely and safe transport of the mother and or infant to the referral facility. Further, we ask that ICI facilities ensure that all maternal and newborn healthcare providers have adequate and ongoing training for emergency skills for the appropriate and timely stabilization and treatment of mothers and their newborns, including the provision of neonatal and maternal resuscitation. All facilities should have available drugs, devices, and equipment to stabilize and treat mothers and their newborns when complications occur, such as hypertensive disorders, severe postpartum hemorrhage, hypovolemic shock, breathing difficulties, and sepsis. And we'll get into some of those specific drugs and devices shortly. Now, beyond those principles of Step 9, there's also the understanding that during an emergency, women and newborns still have the right to prompt and effective care following the current evidence and delivered respectfully. And principles of informed decision-making, communication, and affordability should still apply. The first 8 steps strive to achieve a normal birth and prevent emergencies. However, we ask that ICI sites are prepared and equipped for such urgent situations. So this will look different depending on the level of your facility. For a primary care and birthing center, staff should be ready to identify, manage, and transfer as necessary. Whereas tertiary hospitals are expected to have all of the components for management that we will discuss today, as well as, of course, having strong referral systems and links to their lower facilities. So whether you are treating an emergency at your facility or transferring to a referral center, all the other steps of ICI are still critical. Women and newborns should be treated with respect during transport and by the team receiving them at the referral center. Women and families should be provided with adequate information to make decisions, even during an emergency. Costs for transportation and emergency care should be transparent and affordable. And skin-to-skin care can be provided, even if it's provided by fathers during an emergency. So I would like to emphasize the Shorey study done in 2016, which was a review showing that father to infant skin to skin contact also had positive impacts on the infant outcomes, including the infant temperature and pain, biophysiological markers, and behavioral response, as well as the paternal outcomes, including parental role attainment, paternal interaction behaviors, and paternal stress and anxiety. So even when the mother is not necessarily available for skin to skin contact, that is another option and a way to preserve step 12 during an emergency. Just as a refresher, the causes of maternal mortality have not changed much through the years. The leading cause of maternal mortality remains obstetric hemorrhage. Indirect causes include HIV-related complications, with an estimate of about 5% of pregnancy-related deaths globally and 25% in sub-Saharan Africa are attributable to HIV in some capacity. Sepsis remaining another leading cause of mortality, followed by hypertensive disorders and unsafe abortion. So, facility readiness for maternal complications for those facilities who are providing basic emergency obstetric care would include providing uterotonic drugs for the active management of third stage of labor or for postpartum hemorrhage due to uterine atony. And this will involve having cold chain for oxytocin or ergometrin, cool dry storage for carbetocin or misoprostol, and in the case of oxytocin, the ability to give a safe injection or an IV line. This would also include the manual removal of retained placenta or retained products of conception. And facilities that are providing BMOC are expected to have ongoing in-service training for evidence-based practices for complications, including drills and simulations, as some complications are rare and you want the staff to maintain their skills. During these practices, we would remind you to also be incorporating the principles of respect, dignity, keeping the family together, maintaining skin-to-skin contact, and so on during those role plays and simulations. For all facilities providing care to women during the childbearing cycle, prenatal, intrapartum, and postpartum, you want to ensure that your staff are communicating with women and their partners and accompanying persons about what is happening during an emergency. When using procedures to decrease the risk of a complication or to treat a complication, the staff are trained to fully inform the women about the risks and prepared to handle a refusal of the use of an intervention, that you're following a tool such as the WHO Safe Childbirth Checklist. That tool is going to provide guidance for the use of antibiotics for infection and sepsis, for the use of magnesium sulfate or diazepam, and for the provision of uterotonics, that the delivery space is being cleaned to prevent infection, and that your facility is prepared for the use of vacuum or forceps-assisted birth. So if your facility is not prepared to manage some of these complications, you want to look into whether or not additional training and supplies are available in order to increase your capacity to manage this. And Dr. Krishnan is going to go into a little more detail about what is your level of readiness and what procedures can you safely perform with the level of providers that are available. And also, there may be policy changes that are necessary that will allow different cadres of staff to perform certain functions in order to allow your facility to be better prepared. If a complication occurs that cannot be managed at the facility where the woman is giving birth, you want to be ready to perform a safe transfer. And Dr. Krishnan is going to go into more detail as well there. In talking about readiness for emergencies, the management of supplies and the organization within your facility is sometimes overlooked as a component of readiness because improving organization and communication at your facility are low-cost ways to improve your facility's emergency response. The Averting Maternal Death and Disability team at Columbia University is what I'm referencing here in creating a checklist and performing a room-by-room walkthrough of the facility to assess readiness and look for ways that you can improve your organization and reduce the time it takes in order to address these emergencies, because we know that during an emergency, time is critical. Knowing where your supplies are is critical, and performing these walkthroughs is a very low-cost way to see what can be improved. And so your supplies that you're going to have on this checklist may be different based on the level of your facility, but you can take a look at this paper that we will reference here for an idea of how to conduct such a walkthrough. So this is an example I love to include from our other partner, Vicki Penwell at Mercy in Action, showing a room that looks quite simple, but it actually does contain all of the emergency equipment nicely tucked away, medication, and a written emergency plan. So this was from the original IMBCO presentation on this step, and I like to include it because I think it's a really nice way to show that even in a simple setting, you can have everything stashed away. So now, an emerging method for addressing emergencies are the use of patient care bundles. Patient care bundles have been developed for maternal sepsis and postpartum hemorrhage treatment as a new strategy to create a more robust system to treat an emergency. The care bundles are aiming to reduce inequitable or inconsistent use of interventions, and they call for increased team communication, monitoring, and debriefing. The Fundación Val de Lili is a 31-bed emergency obstetric unit in Colombia, and they are a participating ICI site. They are an early adopter of the postpartum hemorrhage bundle, which combines the uterine balloon tamponade with a non-pneumatic anti-shock garment as standard practice for managing obstetric hemorrhage. So the Fundación Val de Lili has found that using the uterine balloon tamponade with the non-pneumatic anti-shock garment has reduced the demand for blood transfusion, as well as the number of hysterectomies that they've needed to perform. And this bundle combines the elements that are recommended by the World Health Organization in their 2018 postpartum hemorrhage due to uterine atony recommendations. So I'm now going to hand this over to Dr. Robert Tillya, who's going to talk a bit more about equipping and preparing rural health facilities and primary care facilities for the safe management and transfer of women experiencing obstetric hemorrhage.
Yeah. At Ifakara Health Institute, we had an intervention where we introduced the use of non-pneumatic and shock garment as one of the emergency tool as an addition to the management of women with the obstetric hemorrhage to buy time for them to reach the facility where can give definitive treatment or to wait for the services. Together with this, we knew that the communication is very important. So the project, we also introduced the use of cell phones to have a closed user group network where health workers they can communicate with the minimal cost, which can help them to get to give information, ask for transport, or at least to get technical advice from higher levels. So on introduction of this, we realized that NSG was very effective and could help many women who had obstetric hemorrhage to arrive to the hospitals and their lives were saved. We had the rate up to 67% reduction of case fatality. Another one of the examples which really showed us that how much the NSG helped and how much the use of the cell phone with the lower cost helped is the case which happened in the southern highlands of Tanzania, where a girl of 22 years delivered at home, and after she bled for 4 hours, and then she lost consciousness. And here's when the relatives or the caretakers had to take her to the dispensary where they had to walk almost 4 kilometers to reach the dispensary, which they went to seek for help. And on arrival, they found one medical attendant at the facility. The medical attendant is a health worker who has been trained just like a cleaner in the facility, is having a minimal training of issues related to infection control at the facilities because their role is clean. But due to scarcity of or shortage of staff, by that day, the medical attendant was alone at the facility. So she had to get assistance from the relatives who brought the lad at the facility to help her to wrap this woman on a NSG while she was unconscious. But a few minutes later, this woman gained consciousness and was completely alert and was complaining of hunger. So she was requesting something to eat. So the medical attendant had to give her black tea. When these relatives, after bringing this lady to the facility, they ran out because they thought that maybe the lady died. So they ran away to look for assistance to take the body back home. So when they came back, they realized that the lady was alert and was talking to them. They were shocked in the beginning, and later the medical attendant had to explain to them what happened and what she did. So they were happy. After that, after applying the NSG, this medical attendant had to request the relative to stay with this woman at the facility so that she could walk almost a kilometer to make a call to the district level, the district RCH coordinator, to inform her about this emergency so that they can send an ambulance to come and pick her. The distance was almost around 180 kilometers from the regional headquarters, where there is a regional hospital where this lady was to be sent. So unfortunately, the RCH coordinator told her that the ambulance was in the mechanics and was not in the condition which they could just hurry come back to this woman. But the RCH coordinator told the nurse to keep on updating her on the condition of the baby while she's trying to see what she can do to make sure that this baby will be picked. But as they kept on, she kept on updating her with the condition of the woman. The RCH coordinator was impressed to see that the woman was still alert and was doing well. So they kept on communicating until the following day, at the same time, the following day. The day when this woman came to the facility was around 4 p.m. and the ambulance arrived at the facility the following day at around close to 5 p.m. So it was 24 hours after this lady had arrived at the facility while unconscious, and then was taken to the regional hospital, and the management was done there, and they were saying the problem was retained parts of the placenta, and she was okay. I came to get this information almost 2 months, 3 months later, where I was told about, it was more than 2 months later, where I met this medical attendant, and she told me about the condition of this woman, and although we had information of hemorrhages in the database, but the story is the one which was given by this medical attendant. So we decided to visit this woman at home, and we talked to her, and she was happy to see that her life was saved. She didn't know, she was not aware of anything, but she was frightened when she woke up and found the NSG, the blue NSG on her body. She didn't know what was it, but later was told that it's the one which saved her life. So she was urging other women to make sure that they deliver at the health facility, because there are equipments which can help them save their lives. She couldn't do anything at home, but while in the facility, her life was saved. So she said that from that day on, she will be attending the health facility, and she will always deliver at the health facility. So here we could see that the communication also is very, very important, because if not communication, maybe this medical attendant wouldn't know how to communicate with the headquarters to get the transport for that and get even an expert opinion on what to do, especially when she's having minimal education, medical education. This is how we saw that it helped, and you could see the houses and the environment. It's very remote. It's a place where it's hard to reach, and the roads were not so good, but having this NSG could buy time for this woman to wait for transport. It could also give time for the family to organize resources for her to be transferred. It wouldn't be a problem, but the problem is if this woman would be bleeding and there was nothing to stop that bleeding, at least for some time before reaching the hospital. The one who is carrying the baby at the middle, where standing at the middle, the one who is carrying the baby is the nurse the medical attendant who received this lady at the dispensary.
Thank you so much, Robert. So we're going to discuss now situations that may require transfer. For the mother, these may be situations where she has high blood pressure, a high fever, excessive blood loss, signs of hypovolemic shock, as Robert has mentioned here, perennial trauma, and other situations where the situation may be urgent and your facility may not be able to manage it. So I'm going to hand this over to Dr. Vijaya Krishnan, who's going to take us through the rest of the presentation.
Hi, everyone. So I'll start talking right away about situations that may require transfer for the newborn. So there are a few of these listed over here. Abnormal fetal heart rate, that's obviously it's being monitored in labor, and any sort of fetal distress or prolonged fetal distress. So obviously, as a care provider, everyone understands where there might be a slight distress and then baby recovers very rapidly, and the gut and the instinct tells us that those babies are going to be okay, versus prolonged fetal distress, prolonged bradycardia, prolonged fetal heart rates that are way above the range of normal. All of those would require, that are situations that you might want to keep in mind that might require transfer. Respiratory distress, irregular rapid breathing after the baby is born. Preterm birth, obviously, any unstable temperature where the baby is too cold usually. Very rarely the baby comes out and feels very warm, but very usually it is the cold babies that usually need additional support and may need transfers. And neonatal jaundice, although neonatal jaundice is probably not apparent at birth, but later on, one maybe in the day post birth, especially for those babies who are born preterm, mothers who have Rh negative blood group, these are all, and mothers who might have sepsis as well, or babies that develop sepsis. Those are the babies that might need to be transferred for neonatal jaundice within a day or two of birth. I also wanted to talk a little bit about assessing your facility and understanding whether, if you have an in-house pediatrician, depending on the kind of facility that you're at, whether you might have a pediatrician who is on call for you, whether you have an in-house pediatrician whose capabilities and your facilities capabilities that you might be able to have the baby monitored in-house, versus those conditions where the baby would need to be transported to a tertiary care facility. So just assessing those things and keeping that in mind would be one of those things that I would think makes the process of calling for help, as well as seamless transfer of the newborn safely, much better and easier. So the issues that relate to the three main causes of neonatal death are asphyxia. Basically, the baby is born with asphyxiated baby whose APGARs are not good, or the baby has had prolonged asphyxia during labor and is born fairly in a good condition but has a secondary apnea. Preterm birth, of course, in those cases, kangaroo mother care can help to a great deal. Sepsis both in the mother and then in the newborn, obviously. Some of the things that we do recognize is that sometimes babies come out and they are okay, maybe up till the cord remains pulsing. We have seen that as well. But once the cord stops pulsing, the baby can collapse because the main source of the oxygen supply to the baby is at that point cut off. There have been cases over the last 10 or 15 years in our care where I remember this one mom who basically, the baby, and perfectly normal, healthy, easily progressing labor, baby is born, and mom and baby are skin to skin, everything is going okay. And then just as I talked to the mom that, well, the placenta has to come out, or should we clamp and cut the cord? And this is about 10 minutes post-birth, and I'm looking at the mom, and the mom's asking me, is the baby supposed to sleep? And I just jump on and I'm like, that baby has actually collapsed. So those are secondary apnea. Eventually we revive the baby. So having the ability for every care provider in that setting, whether it's the obstetrician, or whether it is the midwife, or any of the other care providers who are delivering the baby, as well as of course a pediatric team if and when present, to have the ability to resuscitate the baby is super important. But in this case, we resuscitated the baby and then we sent the baby out to a tertiary care center, and eventually that was presented as a case because nobody could recognize why this baby collapsed. There was no meconium, there was no aspiration, no nothing. So there are some cases sometimes that can happen. So knowing that secondary apnea and secondary collapse can happen is super important. When in transit, that is the time when the babies can actually have an episode which might cause death as well. So understanding the capabilities of the transfer team, the ambulance, what do they have, whether in terms of whether a continuous positive pressure airway, whether it is any kind of drugs and medications, whether it is an actual ambulance, or whether it is sometimes people transport in their cars, and you want to make sure that at least the baby has somebody there is someone with the baby who can continue resuscitation while the baby is being transported. So what is the approach to newborn needing emergency treatment? We talked about this, helping babies breathe, or the American Heart Association, the neonatal resuscitation in India. We have something which has been instituted by the government at a government level to decrease neonatal mortality, and it has been very successful. It's called the Golden Minute Project, and literally everyone in any facility at any time, on a rotation, is being trained by teams of pediatricians to help with the most basic of the newborn resuscitation. So everyone being able to have some amount of resuscitation skills is what saves the baby. So one thing that we all do know, and I would like to reiterate over here, is that about 10% of newborns will require some kind of stimulation / resuscitation. Out of that 10%, 1% will need further extensive resuscitation or perhaps tertiary care transfer. So if we can take that 10%, and out of the 10%, 9%, if we can give the immediate breaths, basically it's the breaths, the ventilation, if that can be given, that itself goes a long way in decreasing neonatal mortality as well as morbidity. The second point over here is stopping any bleeding. So if the cord is not being tied properly, or if there is not a clamp, being able to retie the umbilical cord. And Vicky Penwell very much talks about, she's a midwife who works in the Philippines. She talks about when in low resource settings, to take a candle and actually burn the cord stump, which seems to be both aseptic as well as in a low resource setting seems to be very effective. But basically, if any bleeding is there, to be able to retie the umbilical cord. Some of the danger signs are listed over here: breath rate which is greater than 60 per minute, any chest indrawing, nasal flaring, all that which you routinely watch in the newborn. Temperature which is very low or very high, obviously, not feeding, no movement, we talked about that, and convulsions, not only your typical convulsions, but also even any eye movements that seem to be abnormal, or any movements of the lower limbs, like abnormal bicycling movements. All those things are signs that the baby might need further evaluation and at a tertiary care facility, and those are the babies who might need transfers. The idea also, again, at any newborn, wherever a newborn is being born, one of the first things is that effective team communication. We will talk about that in a minute. But even for the pediatric, whoever is going to be at the pediatric end of the table, it might not be a pediatrician in a low resource setting, but whoever is going to be at receiving the baby essentially comes in and asks for help and says, can I have one person to help me? Does this person know how to call an ambulance? Does this person know the ambulance driver's number? And can the person count with a clock, basically, for 6 seconds? And those simple steps are all you need to be able to understand: is the baby breathing? Is there a pulse rate? And what are the next steps needed for resuscitating the newborn? Of course, having a bag and mask handy, and always assessing and making sure that those are available is 100% required. But essentially, if we can stabilize the baby, open out the airway, and then be able to stabilize and able to transport. Most of these babies who are even, a little slow to come around or have later a delayed transition to newborn breathing can actually be helped fairly easily. So I talked a little bit about this, but we'll talk a little more now in terms of what are good principles of transport. Basically, having a good prior communication with the receiving center. So having in every resource, every kind of setting, there should be a person who has the numbers of, like I told earlier, like the ambulance driver or anyone who's ready to transport the baby, but also a phone number for the receiving facility. It can be a point person at the receiving hospital, and they then initiate their response and send their ambulance along with the pediatric team. It could be the number of the head of the neonatal unit if you think that it needs a further a more stronger kind of effort to revive the baby or to give assistance to the baby. That would be something that would be needed. So definitely having that communication channel open, and also ensuring that they understand your model of care, and knowing what kind of facility you're transporting from, I think eases the transfer to a large extent and avoids communication errors. As far as the family is concerned, it is extremely stressful for the family. Here is a moment when they should be actually enjoying the birth of the baby, but instead there is all this activity going on. People, obviously, when there is an effort to stabilize the newborn, there is lots of people walking in and out. There is tons of things which are being said over the parents' heads to just make sure that the baby is safe, which is absolutely essential. But then once things calm down a little bit, explaining to the family why that transfer is necessary, what to expect. For example, I know at my center, when we send to a tertiary care, I kind of know their practices. I know that if that one of the parents can go with the baby. I know how many people are allowed inside the ICU at any given point of time. I know what are their practices surrounding, oral feeding and even, express breast milk feeding. I know, for example, that whether, what is the situation in terms of the parent or the parents, both of them waiting outside, whether it's in a waiting room, or does this hospital have rooms for rooming in for the mothers. So all these things are good to have an idea, so that can be explained on the side. And the person, once the pediatric team takes over, the person who has actually either helped the baby be born or the person who is supporting the mom essentially can take over that role of calming the mother down, calming the parents down, and explaining the things, and allowing then the pediatric team to explain the condition of the baby, right? And if mother and baby, it's possible for the mother to go with the baby, that is obviously optimal. But in many conditions, as even after the baby is born, even if it's born vaginally, mom might take some time to be able to go with the baby. Or if there is a cesarean section, then obviously mother is going to be at the delivering facility, and the baby has to go to the tertiary care center. So that's something that needs to be also kept in mind. Obviously, in any team, it is always good to have one skilled team member for the mom and one skilled team member for the baby, because if the baby needs resuscitation, and if the mom is having postpartum hemorrhage, it has been the previous section, this was talked about, that one of the most killers during the period of the labor and birth is postpartum hemorrhage. So if the mom's having postpartum hemorrhage and the baby needs resuscitation, the same person cannot do everything. So having at least one skilled person for the mom and one skilled person for the baby becomes really important, so that the mom can be stabilized as well. Allowing breastfeeding and skin to skin contact whenever it's possible. This, I think, again becomes super important. Sometimes the baby baby is otherwise okay, is fairly stable, but just has a really high respiratory rate, So if you do have an oxygen monitoring system, you can hook the baby up to the oxygen monitoring. What is the SpO2? How is the baby's heartbeat? That can sort of show itself. Or if you have determined that the baby is otherwise well, the color is okay, even in a low resource setting, everything seems to be all right. But if the baby can be stabilized with just a little bit of nasal oxygen, whether it's with a prong or whether it's a blow-by oxygen, but the baby can be kept skin to skin, how many times do we see that the respiratory rate actually comes down, even though it may not come down to the level of being able to the baby to be kept right there at the center, but baby and mom being together goes a long way in helping the baby's respiratory system also stabilize and helping the mom to feel comfortable with the baby. And even before they leave, even if there is an emergency, before the baby is shifted to the tertiary care center in the warm garment, the baby can be brought skin to skin, kept with the mom for a few seconds, and that allows her to feel that this is the reason why she has done all the hard work. And it also makes the ICI principles of respectful care, communication, and effective skin-to-skin support for the mom and baby, and to be together as much as possible. All these come together to help the family, come together even in times of stress. Of course, ensuring safe mode of transport, sending an accompanying healthcare worker if possible. So we have, examples of that. Either the tertiary care team obviously comes with all of their support systems, but when that is not possible, sending somebody from the facility, whether it's a nurse or whether it is and somebody else a nursing assistant who can go with the baby, again helps to not only stabilize the baby but also have another pair of hands to help should the need arise during transportation. Request communication from the referral facility about outcome, and this I think is so critical. One of the things that parents who come to your facility, wherever you're at, they do come because they trust you, right? So they still want you to be the point of contact to talk about how the baby is doing. Like even though the one of the parents may be there, and every day there are rounds, and the responsible pediatrician may be explaining it to them. Remember that they explain in medical terms, and though they may understand some of those things, they may still not understand other things. And so if the person at the pediatrician, the pediatric team at the referral center has a direct communication with you, and then you are able to sit and talk about this and answer other questions they have, the situation eases so beautifully. And one of the things that I have had the honor of in the last many years is that we have had an excellent tertiary care facility. We have built the relationship to a level where every day the head of the unit will call me and appraise of how the baby is doing, and we will talk about when is the baby's oral feeding started, is the mom expressing and feeding, and then that sort of allows us to go back and talk to the parent who is there at the facility, and then either the parent goes to the baby or the baby comes back to the parent, and things are so much more easier once the lines of communication are open. And it also allows you at some point to determine and debrief your own team about what things could have been better, where could things improve in terms of if things like this happen the next time, and also where you did well, and sort of pat yourself on the back, if you will, because in stressful situations as healthcare providers, we all know that we lose a few years of our life each time these things happen. So it's also good to pat yourself on the back and say, well, all these things worked well. These are the things we could have done better, and also allows you in terms of any peer review or any sort of going back and looking at a case review as well, and determine if the mother will come back for care or follow up. So if the mom's going with the baby back into the tertiary care center, or if they're going to be discharged home from there, coming back to you as a mother-baby unit, whether they will come back to you for care, that again determines the kind of instructions and the kind of information that you would provide to the mom at discharge. This is primarily for the mother. I think this is or the or the parent or the caretaker for the baby, that what are some of the things that they could be looking out for, especially if the baby is at your center and is being has had a sort of in-house NICU or a slightly prolonged a stay at the center for any of the newborn needs. This becomes extremely important for the mom to understand, especially in terms of the danger signs for the baby, as to what they should be calling for and coming back. So too hot or too cold, any convulsions, yellow palms and soles, obviously that's for the newborn jaundice. If the baby is not having any movement, baby is just not feeding well, not waking up for feeds, and any fast breathing or chest indrawing. All of these are important. And of course, the danger signs for the mother, I think the other presenter would have discussed before. I did want to take a minute and talk about breastfeeding, because again, when we come look at the ICI 12th step, we are looking at both establishing breastfeeding as well as giving mother all the information regarding the best practices regarding feeding for the feeding the newborn. So if the mother is to be separated, because again, this is where I feel that sometimes in the high adrenaline of transferring and keeping the mom comfortable, we sort of leave this to one side, and it doesn't need to happen that way. So if a mother will be separated from the newborn for any significant period of time, and this might be within an in-house ICU as well, because there are times when we might not transfer the baby to a tertiary care center, but the pediatrician in the in-house facility might be keeping the baby in the NICU. Say, for example, just a respiratory rate, it's like a transient tachypnea, but which is lasting for a much longer period of time, right? So in that case too, it is worthwhile considering starting pumping. And typically with a normal delivery, the mom might be ready within a few hours, as soon as she feels relaxed, she has seen the baby, or if the baby has been transferred, she has rested for a while. So within 4 to 6 hours, they can start pumping. And if it's a cesarean section, typically we start pumping within 12 hours. That's been our practices. I know there are facilities around the world that might do it sooner as well, but somewhere we have found out that about 8 to 12 hours seems to be a sweet spot where the moms feel reasonably physically okay after a cesarean to start pumping, because it's not just about us saying here's a pump, but how's the mom feeling, is her pain control okay, and all those things also determine it. But so what does this pumping do? It's not about sitting in hours of pumping, but the number of times, the frequency. Even if she does 10 minutes every 2 hours, it not only sets up a demand, but I guess the other part is that it also ensures that the mom feels that she is actively involved in her baby's well-being. It also allows for expressed colostrum. So again, like I said earlier, if you know your partner facility, as soon as they start like a OG tube feeding, or if they start a spoon feeding, if the expressed colostrum is available, we would collect it in syringes, keep it in the fridge. The partner might come in every couple of hours and take it for the baby. So it just provides that additional level of good antibodies to the baby who is recovering, and also allows for the mother-baby dyad to thrive in a much better manner. So this is if this transfer cannot occur. Now we have talked up till now, we have talked about what if the transfer occurs. If the transfer cannot occur, if there is no ambulance, whatever, low resource, no fuel, no roads, emergency situations, obviously, again, having established some communication links with professionals, that is very important, so that they know that this is the situation at your ground level, and providing whatever is available. So ensure, first of all, knowing what your facility is capable of is very important. So minimal things absolutely are possible for the mom as well as the baby. Circulation with IV fluids, oxygenation, either for mom or for baby, easily possible. For the mom, I think this has again been probably discussed earlier, but uterotonics to keep the uterus contracted, making sure that there is minimal blood loss, or wherever, if that's applicable. If there is shock, keeping the first aid device as well as any garments that are available to stabilize the mom, and so that she doesn't go into further shock. Continuing any antibiotics if there is sepsis, either suspected or actually known sepsis, both for the mom as well as for the baby. Breastfeeding, We talked about that, keeping the mother and baby warm, keeping the mom's bladder empty, because we know that when the bladder is full, that can again cause periods of bleeding, and that's something we want to avoid. And if the mom has had either is in pre-eclamptic state or has had an eclampsia, continuing the magnesium sulfate is absolutely important until the mom stabilized in the center, or even if she's going to be transported out. So this is talking about some of the challenges that may be there, and how you can also look at a facility-wide policy to ensure that things are smooth when these kind of situations arise. So shifting some emergency care procedures to other type of providers. So the way I look at it, I look at assess your own confidence at dealing with whatever condition for the mom or the baby that might be there. Assess the competence level. What is your competence? For example, if there is a breech birth, are you competent? Is your staff competent in delivering a breech baby? Or if there is for newborn resuscitation, do you have enough number of staff competent at newborn resuscitation? Are they certified? Is a level, and what is the level of safety you can provide? And I feel like this should be an ongoing assessment based from antenatal, during labor and birth, as well as postpartum, because there might be cases, for example, where you might be able to handle like a mild, like my facility, for example, might be able to handle a mild hypertension, but a hypertension with twins, it may not be able to handle. So it is up to us to assess what is the level that I can provide safe care, and when should I shift them out to another tertiary care center with multi-specialty and as well as multi-special, not only care providers, but all levels of support available, right? For the preterm baby, for example, if the baby is, for example, 2 kgs, and if the baby is somewhere about 30 to 33 weeks, I know that my facility can take care of that baby. If the baby is less than 1.5 kgs, even though the baby might be, say, 35 weeks, I might not be able to care for it. So assessing those things are super important, and ensuring that you are able to transfer that mom out even before the birth, especially in where I am talking about the newborn, actually gives better mother-baby results, optimal outcomes for both mother and baby as well. And establishing relationships. We talked about this, because if I can pick up the phone and I can call another center and say, hey, I have someone, she's got IVF pregnancy, her baby's growth is in the 7th percentile, up till now she has been okay, but now, her BP is also shooting up and her fluid levels less. I would rather transfer it to your facility. That becomes very much more of a safe proposition for that mom. And then, of course, when the baby is born, they have that level of care that the baby needs as well. So what are some of the conversations about step 9 at your facility? What conditions are you prepared to manage? That's what I talked about in the previous slide. What conditions might require a referral? How often are staff refreshed on emergency procedures? So we do need to do drills often, and with different kinds of drills, with different kinds of situations, and with different team members. Some of us who have smaller facilities, and I know because mine's sort of I won't say a super small, but it is also not, I think it's somewhere between small and mid-level facility. One of the challenges, for example, that I have is that our nursing staff, for example, works on shifts. So when I do, say, a drill, or I do an interdisciplinary team drill, sometimes because of transportation, cost, tiredness, whatever, the night shift may not be able to come for the drill whatsoever. So making sure that we manage to, land up doing those drills at other times where everyone's available becomes very important. Who are your referral partners? How does your communication happen? We talked about this earlier with the other facility. During an emergency, can that communication channels be better? How are the families received during the maternal and neonatal emergencies? Because again, how how they are received at the tertiary care facility also is sort of encompasses that overall birth experience for them, right? And are they prepared for any additional cost that the emergency referral might have, and could we somehow ease the financial burden? For example, again, one of the things that we might ask when the partner is leaving with the baby is that, do you have money for admission? Can we provide you some money up front so that you can then admit, and later on we can worry about the finances? So those sort of conversations essentially make it easier on the parent who is already stressed when a transfer is happening. So take-home messages: lower level facilities should have staff prepared to identify and respond to emergencies. Most of the times birth is beautiful. It happens, everyone's happy, everyone, sort of does what they need to do and lets the family enjoy that moment of birth. But when an emergency arises, it can be extremely stressful on the care provider team. That is the first thing that we have all got to acknowledge. And then, of course, to the parent, it is equally stressful as well. So having that ability to respond to emergencies is very important. And like I said, debriefing is very important. Sometimes after a major emergency, we as a care provider might not want to step into another birth. And many of us live in geographically isolated areas where not enough of communication and debriefing might be available, and that level of support may not be available. So hopefully things like the ICI might bring together teams of people who might be able to engage in these kind of conversations across the world. So everyone as a care provider team is also feeling well supported, right? So that's one. And then the tertiary care hospital should have all the necessary training materials to address the maternal and newborn emergencies. And they should be, you should have a good communication going back and forth with them. All facilities should have clear referral pathways with good communication when it is possible, and of course during transport as well. And respect for the woman and the family must continue throughout. Respect and kindness cost nothing, and just that taking that 1 minute or 2 minutes of time to talk to the parent and say, you know what, everything is going to be okay. Everyone's working really hard to, make sure that your baby is all right. I'll just come back and talk to you. Just that 1 minute makes the mom or the partner or whoever might be feel a little more comfortable at that point of time.
Thank you so much, Vijaya and Robert, for covering all of these components of how to deliver safe and respectful care during an emergency. I'm just going to pose a few questions for discussion as we wrap up this session. So I wanted to ask you, because I know we didn't talk about it before, when do you start having conversations with your families about emergencies? When do you start preparing them? Obviously because today we're talking about what happens when it happens, and then how do you communicate with them during it. But for you, when do you start to prepare them?
At their first visit. At their very first visit, when we go through our informed consent as well as for the financial information, we do both of that in both those situations, because they should be prepared even financially, that in case the baby has to be transported or the mom has to be transported, that there might be additional costs than what they owe to us, right? So both from the financial perspective as well as from understanding that if the baby needs a transport, that can happen, that it doesn't happen very often in a normal healthy low risk woman, but when it does, that this is the facility. We even talk about what's our referral facility, and usually how long they will take to come there, everything. So they know that entire scenario, that if the baby needs it, within 10 to 15 minutes somebody will be there to transport the baby.
That's wonderful. And I really like a couple of the points that you made that we hadn't discussed. The idea that some of the messaging should come from you if the parents are referred out, that then you would want to get that information from the facility and then be the one to also speak with the parents to have that continuity, because obviously you have a relationship with them already. Yes. And I think that's something you haven't highlighted, the importance of, or sort of the comfort level, because maybe they might have received the same information from the next facility, but they're going to feel differently, or maybe they'll feel differently about asking questions if it's coming from a facility that they are more familiar with.
Yes, yeah, very much so. Just the very idea that sometimes when they go to the tertiary care center, for example, there is a registrar over there who may not be really schooled in the more gentler and softer aspects of communication, right? So from here, they're going saying that, well, it's just that the baby is breathing a little, little faster than what we want at this point of time. I think there'll be more eye over there. But then they go over there, and what's the registrar taught to do? The registrar is taught to say this can take anywhere from 48 hours to 72 hours, and up till 72 hours we can't say anything. That's what they are told to say, because they don't want to take on and say something that, well, everything is great, so that type of thing. So when we already tell them, for example, that this is what they will. So again, knowing the tertiary facility is so important, because you can tell them that the person who's receiving the baby over there might say that the baby might need slightly longer than what we anticipate. Don't worry about it. The first 24 hours will be critical, and then we will come back with the feedback to you, and that I will get a status from the referring facility, and I will come back to you. So I think that relationship, and like you very rightly said, they have, like, I feel they have the trust with us and the continuity of care, and just being able to, for them to feel that support level is coming from all quarters, that now the baby is born, that we are not just leaving them alone, does make a huge difference.
Exactly. I think it does happen in many cases where some families get transferred and then they feel sort of like an abandonment or just a distress from the transfer. I think it's really good that you focus on sort of closing that loop. And then also, I can't believe we didn't highlight this more in ICI, but having your team debrief is obviously critical. Having that time for the staff to talk about what has happened. I know you already covered it. I just want to reiterate that that's something that I think we need to bring forward more. The importance of that.
Periodically, every quarter, we go through, like even for newborns, we go through our transfer statistics and say, okay, what happened? Why is in this quarter, why did we have more transfers, for example, and why in the other quarters it didn't happen? Funnily enough, in I think it was in 2019, if I'm not mistaken, or it was in 2019 or 2018, we had had one not non-optimal outcome. And so my backup care provider, my backup OB, she was like a little fussy about, now, what, I don't know about this, because she ultimately, the responsibility falls on her as well, right? So she said to us that, well, we should have a doctor at every birth, and maybe they can sit outside and have a pediatrician present at every birth. And I was like, oh my God, you and I have known each other for a gazillion years. What's going on with you? Anyway, that's how it works. And so sometimes you have to pacify everyone and make sure that they don't feel under the gun. And so we all debriefed. We did a full debrief of it, but still, that was it. So funnily enough, that quarter we had tons of transfers. So I started, like, tons as in like 15% or 20% more than what we would normally have. And when you go back and look, I was like, nothing had changed except that we were all expecting an emergency. So every birth at the doctor, there were lights, there was sound, there was people in, there was pediatrician. And then I said, can't do this anymore. Next quarter, it came down. Because, I mean, like, this is not the way the birth is supposed to work. If you have all of these people hovering around, and either I start to feel the pressure and start making some, maybe hasty sort of like, okay, this birth has gone on for too long, mom is pushing for too long or whatever, or the birth physiology goes for a, toss, and then you have something, all this happening. So really, it is very, very critical to look at different ways. One is, of course, we have our register where we are looking at, for the maternal side, in terms of any outcomes that could have been better, like it doesn't necessarily have to be one way, it's not necessarily only that the medical way is wrong, but did this mom push for too long, that also we have to look at, like, was it required that she pushed for so long, so things like that. And then, so that's one part of the register. Sorry, you want to ask something?
No, I just wanted to say, so what you're describing, because it goes back to what you had said earlier, was the confidence. And so like
Yes,
there was a decrease in the confidence of the team, and that resulted
exactly,
in that.
exactly, exactly.
No,
Yeah.
it makes sense. It makes sense. And so it's very important to keep that, to keep the staff also feeling sort of reassured and comfortable.
Absolutely, everyone, the entire team, your backups, your own staff, they feeling that they did everything that they could at that time. We had a twin that collapsed after the third day after the babies were born. She had mom with PIH, so many things, everything going well, but the mom was very, very large. And I think she just fell asleep, and the baby just, she the breast fell on the baby or whatever. Honestly, I expected that the baby would be dead when I arrived. I mean, that's something you don't. This is just like the nurse calls me and she's like, she's just taken the baby and run the baby to the NICU. The mom's like outside, the dad's weeping, and so she and the housekeeping are alone in the facility. Which at that point of time, we are just waiting to discharge them the next day, right? And so in her mind, she's like, ma'am, she's calling me, putting me on the phone and saying that this baby is not moving, the baby is blue. And like, I am listening to this and I'm saying, have you tried the Ambiovag? And she had not in that 1 minute. So like, even though this was day 3, I mean, in your mind, you are looking at bagging the baby at birth, right? But you're not necessarily thinking that suddenly this baby is collapsed and you're going to bag the baby. So it was just that moment. And like I was with her on video and I'm running out, and like every member of the team, I was like, everyone get out of bed. You're coming there right this minute, And then I'm like, okay, running and saying, and then by the time I reached, I reached within maybe 10 minutes. And when I went in, I was expecting that this baby would be no more, and the baby was okay. So it's just that whole thing, no? So how do you debrief the whole team after that? What did we do? What did we not do? That keeping that any time it happens, top of the line, airway should be open. Let the baby get the breath. If nothing else, all those things. I just think that it is a constant, ongoing mechanism, and I don't think any of us should take that lightly, because that saves lives.
Yes. Oh, I want to thank you so much. This was so wonderful. You have such a rich experience to bring to this step. So I appreciate it.
And thank you so much.
My thanks to everyone who's joined us today for this session. I hope that you will go on to watch the rest of the recordings and that we'll see you again very soon.